Hi everyone, good afternoon. This is Dr. Dave. We are live from Thousand Oaks, California, Los Robles Hospital and Medical Center. And this is a very complex patient, a 65-year-old lady with multiple behavioral problems and was found about 12 days ago by her family on the ground, very short of breath, altered level of sensorium, and was brought to the emergency room, was found to have urinary tract infection and was initially treated for sepsis, but was very hypoxic. And evaluation with CT pulmonary angiography showed bilateral pulmonary embolism. She also had bilateral deep venous thrombosis. She was obviously started on full anticoagulation and oxygen support. Her hypotension responded to IV fluids, but her cardiac enzymes were elevated, and initial elevated troponin was attributed to pulmonary embolism because that can cause, obviously, high-risk pulmonary embolism would cause troponin elevations. Over the next few days, patient continued to not perform well and then became progressively tachycardiac, hypotensive, and tachypneic, required BiPAP support. And the cardiac enzymes went up further, and the troponin levels peaked at about 5,000. Also, her echocardiogram in the beginning was obtained, which showed the left ventricular function was normal, and right ventricle was not dilated. So initial plan for doing a pulmonary thrombectomy was not considered appropriate, as the patient did not have enlarged dilated hypokinetic right ventricle, which would be an indication for taking her for pulmonary thrombectomy. However, a second echocardiogram done 5 days later showed her ejection fraction had been reduced to about 40%. That, along with elevated troponin, prompted us to bringing her to the cardiac catheterization lab after ruling out sepsis and numerous other things. Her level of sensorium has improved since then, and we brought her yesterday to the cardiac catheterization lab. And this live view of the angiogram that we see now was the left ventricular angiogram that was done at the end of the PCI procedure. And as you can tell, the ejection fraction is about 20%. The high lateral, very proximal anterior wall, that's the only thing that's contracting. All other segments seem to be hypo or akinetic. And this is what her coronary arteries look like. The left main was okay. Very extensive calcification in the left anterior descending artery. You can see most of the coronaries even before the contrast is injected. Subtotal occlusion in the mid segment of the LAD, but the distal left anterior descending artery has extensive atherosclerosis and is very small in caliber. As you can see, very proximal circumflex artery has a subtotal occlusion as well, which is like a short shelf-like lesion. And there is a distal obtuse marginal branch that has disease. And as you can tell, the right coronary artery has high-grade stenosis as well. The initial thought was to evaluate for cardiac surgery. The cardiac surgeon looked at the echocardiogram, the LV function, patient's bilateral pulmonary embolism, diabetes, psych problems, and persistent hypertension and tachycardia. And she was deemed to be a prohibitive risk for surgery. So I was charged with the responsibility of trying to revascularize this percutaneously. So we decided to proceed with PCI, and we thought if we can get the major segments of the left anterior descending artery and the very proximal circumflex subtotal occlusion fixed, and then put her on hemodynamic support and re-evaluate and see how things go. It was tough to cross the blockage with any balloons. Fortunately, finally, we were able to get a sprinter across, and then sequential dilatation with 1.5 and 2.0, and then balloons. And then finally, we got our first stent. Next. And we had a wire in the left, in the circumflex artery as a support. Next. Next. So that's a long stent, 28 millimeters, and covers the entire disease segment, but the ostial left anterior descending artery still didn't look very happy. And the mid to distal left anterior descending artery has some mild dissection, but the flow was brisk. This stent was post-dilated at 22 atmospheric pressure, and then next we decided to go ahead and fix the proximal circumflex artery with a stent. Next. And that's another stent. I think it's a 3.0 by 16, covers the entire disease segment, and we stayed clear of the left main coronary artery there. Next. I did not like the ostium of the left anterior descending artery, and we decided to put a stent there and make sure we had no issue with reocclusion in this very sick patient. Next. So that's what is nearly the final result of the circumflex and the left anterior descending artery PCI. The proximal up to the mid segment of the LAD and the proximal circ, those lesions look great. There is distal part of the LAD, the flow is brisk, but there is a dissection. That vessel is too small, I thought, for putting in more stents. And that area was likely scar tissue, so we didn't want to waste more capital in terms of contrast, x-rays, and time. So we decided this would be a good time to take final pictures. We looked at the left ventricle that you saw before, and then went ahead with and put the patient on Impella left ventricular support. And next, last picture, yeah. So here is an Impella device in position, and we were able to get very good flow at P9, about 3.5 liters per minute. Patient remained hemodynamically stable and was transferred to the coronary care unit yesterday. Since yesterday, things have stabilized. We were able to get her off the levofed that she was on, and we decided to bring her back today to fix her right coronary artery after evaluating the left coronary system. So this morning, we just now got access, and we have our catheter in place. Actually, let's show the first picture that we already took of the left coronary system. So the proximal to mid, the stents look great. Brisk flow is noted. The left anterior descending artery has that dissection flap in the mid segment. I'm still thinking what we might do. And the size looks slightly bigger than it appeared to me yesterday, so it could possibly take a 2.5 millimeter stent. All right, so what we're going to do now is go with the right coronary guide catheter and see if we can get the right coronary artery vascularized. I think the plan would be to cover the entire disease segment. And seems like it's a 30 millimeter long segment approximately, if not 35. And the vessel size is beyond the lesion, it's about 2.5. The very proximal may be slightly bigger. And as you can see in that frozen frame, the lesion is subtotal. Here is our wire coming up. That's our workhorse balanced middleweight wire. Now it wants to go into the branch. Okay. Could you give me some contrast here, please? Yeah. Okay, so we are right at that subtotal occlusion. So we may need a hydrophilic wire to cross it. And we also may need a balloon to support its movement. I was worried about wiring this lesion because it's so long and subtotal and on a tortuous vessel, but I think we're making some headway. We're past the worst lesion into the second branch. It will choose every branch on the way now. The third branch. Now the RCA main. Okay, let's get the balloon back. Take a picture. All right. Distal segment could take some dilatation. Good thing is nothing bad's happened so far. We are in good shape. I'm going to get the balloon and dilate the distal part, and then we'll take see what stent we can get through it. Let's try a 2.5 by 38. We have maybe a millimeter, maybe a couple of millimeters more to go. And distally, I think we're in the right spot. If everything else looks stable, we might see if that mid LED can be optimized. Okay. All right, here is the final picture. I think that looks very nice. So balloon and wire are out. Pressures look excellent. Show me the left coronary system again, one more time. I have mixed emotions about this. Question is, there is brisk flow, there is a cap, but lumen is open, and it's very heavily diseased vessel. And we would be going through stents. Let's take a guide. Let's take a look at it and see if yeah. Okay, let's take a new BMW wire. See if it would. Give me a torquer. Introducer right there. Trying the balanced middle weight, the BMW wire, and we'll see if we can cross into the LED past that area of dissection. So far, so good. I think we're in the getting all the branches here. There is a branch that goes straight down to the apex, just like that. That's the one. Do we have a 2.0 by 30 balloon? Do we have 2.0 by 20? Okay, let's take 2.0 20. Yeah. We just do a low pressure inflation a little longer to see if we can tack up that dissection from yesterday. If we'll also know whether the balloon goes through the stents easily. If it just flies through it, then we may be lucky enough to get a 225 stent, and that should hopefully fix this. Bothering me. Okay, let's take a 225 by, what do we have? Do we have a 38? So we covered that dissection and proximal to it. Leave the distal vessel looks nicer. If we covered the flap, I think we'll be happy. I don't think she's ever going to get a Lima, so I don't mind covering that area, considering how things are. The main fear here is that if the edge of the stent cuts through the vessel, you could actually perf, and that's obviously never pleasant. But I think here, now all those septals are coming from a wide open artery, and the distal artery looks the way it was. I think we pushed our luck enough, and I think we're done. Let's call it a day. Okay.